Hello, Apex Nation. My name is Jeremy Heiner.
And I'm Sas Elisha.
We're the hosts of the Apex Live Anesthesia podcast. And we want to thank you for tuning in again for another episode.
As always, this is a podcast for CRNAs by CRNAs, where we want to provide you with the most practical knowledge and wisdom that you can use in your practice today. And we want to welcome you to another episode.
So what we're going to talk about today is a hypermetabolic tumor, but we don't want to give it away because we're going to start this out with a case study. So hang tight. We're going to get going with that in just a second. First off, we want to talk about what we offer from Apex Live with regards to virtual conferences. Guys, we got some CPC assessment virtual conferences ready for you, and we do them in a fun and clinically relevant way.
Yeah, we're going to do education differently. You're not going to sit in front and watch a Zoom and get completely bored, where it's so easy to have Zooms become very boring very quickly. We're going to do a comprehensive review for you, teach you all about the CPCA while providing practical tips and things that can help you in your clinical practice. But we also believe that you should have fun and enjoy a few laughs along the way with you as a member of the Apex family.
And hey, everyone, we have one more virtual conference left in 2021. It is in December. It's already prior approved by the AANA for 20 Class A credits. So check it out at apexlive.com. And guess what? We offer flexible times so that it's easier for you to fit those virtual conferences into your busy schedule. Because we know what it's like to go into the OR all the time and still have to get those CEs. Check out our conferences at apexlive.com to learn more.
And as an added bonus for listening to our podcast and putting up with Jeremy and I, if you sign up for either of our conferences in 2021 and use the code podcast, that's podcast in all caps, podcast in all caps, you will get $50 off the registration fee.
And we'll have more conferences, more virtual conferences in 2022. So stay tuned for details. And with that, let's get to the episode. All right. So we talked about having a case, and this was an actual case in the OR that we experienced. And I'm not going to give it away yet, even though it's in the title. So here we go. We have a 49-year-old female who is scheduled to have a liver resection for a mass in the right upper liver lobe. This was confirmed on CT after routine blood work revealed elevated liver enzymes. She has a significant past medical history for migraine headaches. She has been evaluated and examined. Her physical examination includes hypertension, diaphoresis, and palpitations. So you look at the labs, the H&H are 16 and 44. The BUN and creatinine is 1.5 and 31. And the glucose is 181. So those are the significant labs that you see. Her vital signs include a blood pressure of 152/92, a heart rate of 66, an oxygen saturation of 97%. And you look at her ECG or EKG, and she's normal sinus rhythm, but with an occasional PVC. You get her into the OR. And after induction and intubation, and after you've confirmed that the endotracheal tube is in the right place, you start sevoflurane and you start it at about 1.5%. You look at the BP and it decreases down to 80/39, which is not uncommon because remember, she has a history of hypertension. Her heart rate only slightly increases to 76. So what do? You give ephedrine, 5 milligrams for the hypotension. And guess what? You look at the blood pressure the next time you cycle it, and it's 196/106 after 5 milligrams of ephedrine. So what do you do now? Well, what we did was we increased the anesthetic depth. We gave some fentanyl, some dexmedetomidine, and we increased the sevoflurane concentration. We also looked at the A-line. We had an A-line going on because this was a liver resection, and we made sure that we re-leveled the A-line transducer so that both the A-line and the BP cuff pressures were very similar. The surgeon started, and when they got to the resection of the liver bed in the right upper liver lobe, the patient's blood pressure, it increased again to 200 over 110. The heart rate slightly increased again to about 82, even though we had a deep plane of anesthesia going on. So you guys, let's think about this. What are the differential diagnoses for extreme sustained hypertension? What we saw in this case was that every time the surgeon commenced resection of the liver mass, the BP reliably and dramatically increased. So Sass, I'm going to ask you, what's going on? Talk to me about some differential diagnoses.
Yeah, so there's a lot potentially going on here. When we talk about hypertension that isn't going to be mitigated by a deep plane of anesthesia, and then the blood pressure continues to go up, at some point you need to think about why is this happening and what's going on. So let's think about some medical reasons why this is possibly happening. So does she have chronic undiagnosed diseases, such as essential hypertension? Does she have renal vascular disease, and that's what's causing her hypertension? Does she have other undiagnosed endocrine disorders, such as hyperaldosteronism, also known as Conn syndrome, or hypercortisolism, also known as Cushing syndrome?
That is a lot of differential diagnoses.
It's a lot, and that's just about disease states. Now, let's think about acute, because that's what we're all about thinking about in the operating room.
Yeah, what's happening right now?
Exactly.
What's causing it?
So, things that can make the blood pressure go up in a sustained way. Someone who's hypoglycemic. You can pretty much rule that out since you knew that she was on the borderline of being hyperglycemic at 180 in the preoperative area. Is she having an MI, or does she have CHF? Blood pressure can be increased initially to increase stroke volume. Now, is she having a CVA? She has this history of migraines. Could the migraines not actually be migraines, but she is having TIAs, and maybe she's having a CVA? Does she have increased intracranial pressure? Does she have some kind of intracranial mass that we don't know about? Also, is she using stimulants such as methamphetamines that she didn't tell us about? All of those things are possible. However, in all of those things, remember what her heart rate was. We started off on the lower side. So if someone's using lots of methamphetamine, usually the heart rate's higher. Someone's having a dramatic increase in ICP, heart rate's probably going to be higher. That is also within MI, CHF, and hypoglycemia. But all of those things need to be ruled out. Now, let's look at anesthesia causes. First one we always think about, patient's light.
And you and I always talk about front shelf and back shelf diagnoses.
Yep.
So being light under anesthesia is definitely one of those front shelf diagnoses.
Absolutely. And that's what everybody's going to think first.
Right.
And as you talked about in the STEM, we have established that the patient has an adequate amount of anesthesia on board. Things that stimulate the sympathetic nervous system, such as hypercarbia, hypoxia, acidosis, certainly can make the blood pressure go up. Blood pressure measurement inaccuracy. So we spent time discussing with you, the arterial line is working. We releveled the transducer. We correlated the arterial line pressure tracing or pressure to blood pressure tracing. So that's not it. Now, could it be a drug error? Certainly. We gave 5 milligrams of ephedrine and you saw that very dramatic effect.
So I remember when I started anesthesia school and things have gotten a little bit better, but in the anesthesia cart, I remember looking at the ephedrine vial and looking at the epinephrine vial and seeing how close they were identically with just a slight color variation. And I remember having a colleague who actually mixed up epinephrine thinking it was ephedrine and having a dramatic blood pressure response.
Yeah. So you have to think about that. until you rule it out as no, you absolutely did not make a drug error. Is it possible the sevoflurane vaporizer is empty and you're not paying complete attention and you don't know what your inspired sevo concentration is? And lastly, and this is a long shot, is someone taking a drug that is an MAOI inhibitor? It would be unlikely, and you would probably know about it, but that's something you have to throw in there. And there are lots of other diagnoses as to why sustained hypertension can occur.
Okay, Sass, so you just outlined a bunch of differential diagnoses. And let's get back to this case. So we had initial hypotension, and we only gave 5 milligrams of ephedrine, which is kind of a drop in the bucket. Let's be honest. We all give that, and we generally don't see this significant of a response to 5 milligrams of ephedrine like we saw in this case. It went up, the blood pressure went up to 190, the systolic went up to 196. And then every time the surgeon started messing with that vascular bed within the liver, we got a dramatic blood pressure response. So what's the diagnosis that we have not considered yet?
Yeah. So, when you're making a diagnosis that is atypical, so a Pheochromocytoma is a possibility, but it's extra-adrenal. They're not doing surgery in the adrenal gland, but the liver. But they're two very sentinel events that are out of the ordinary. The ephedrine, as you described, and this every time there's resection, there's a dramatic increase in the blood pressure. So what we did is pretty much what every anesthesia person or people would do, is just absolutely deny that it's, deny that it's something bad, something like a pheo.
I'm not going to see a pheo.
Exactly. So, no, it's the blood pressure cuff. Oh, no, the blood pressure is not really that high. And making excuses. When we communicated with the surgeon about what was going on and the dramatic increases in blood pressure, we all came to the decision that it is possible, although very unlikely, that this could be a Pheochromocytoma. So let me do a little bit of review for you about a Pheochromocytoma, what it is, and some of the demographics. So a Pheochromocytoma is a catecholamine-secreting tumor, and they are most frequently located within the adrenal glands, either one or both. Pheos affect, they believe, about 2 in every 100,000 people, which is why when someone goes to the doctor and they have hypertension, certainly the initial diagnosis is not a Pheochromocytoma. Now, it affects people most often between the ages of 30 and 50 years of age, and it accounts for 0.1 to 1% of all hypertension. Most pheochromocytomas are norepinephrine secreting tumors. So think about norepinephrine, huge amounts, max alpha stimulation, and that is certainly going to result in hypertension.
Now, Sass, you said that some pheochromocytomas can be extra-adrenal, although a lot of pheochromocytomas are within the adrenal glands. Can you clarify what that means exactly?
So most pheochromocytomas occur in a single adrenal gland. There is a genetic syndrome called multiple endocrine neoplasm. So if that's the case and that's your situation, it is possible to have bilateral pheochromocytomas in each adrenal gland, and that's what is most commonly occurs. However, in a small number of pheochromocytomas, what occurs is they're extra-adrenal, that they're not in the adrenal glands, and that accounts for about 10% of pheochromocytomas. When this occurs, when they're extra-adrenal, about 10% of the time, 75% of them exist in the abdomen. It is very, very rare to have an extra-adrenal pheo in the liver, but there are case studies that this does actually occur.
And this occurred with our case. So we saw that. All right. So now we talked about some of the signs and symptoms in the actual case study, but can you just kind of clarify what are the signs and symptoms of a pheochromocytoma?
Yeah. So ideally, a pheochromocytoma is diagnosed ahead of time. No one ever wants to take care of a patient with an undiagnosed pheochromocytoma. When you think about the signs and symptoms, and I'm going to go over on pre-op, what could certainly be clues to the possibility of pheochromocytoma, think norepinephrine, huge amounts, and think alpha adrenergic stimulation and what the physiologic effects are. So first, a triad of symptoms associated with a pheochromocytoma: headache, palpitations, and diaphoresis. Now, on physical exam, she has palpitations, PVCs. She also is diaphoretic. Now, when we looked at her history, what did it say? It said she had migraine headaches. Is that headache really a migraine headache? Or is it a headache that is occurring because she has a pheochromocytoma? Next, paroxysmal hypertension that can dramatically increase. Look what happened with our 5 milligrams of ephedrine. We gave 5 milligrams of ephedrine. Ephedrine has an indirect effect, causing the release of catecholamines from presynaptic nerve terminals. In people with a pheochromocytoma, those vesicles within the nerve terminals are packed full of catecholamine. So whenever there's a release, there's an enormous adrenergic or sympathetic response. Let's take a look at the labs. She was hemoconcentrated. That makes perfect sense. The reason, so tightly vasoconstricted. In addition, not mentioned here, volume depleted also. So that's another sign that occurs with someone with a pheo. She has increased BUN and creatinine. Why is that? Well, she certainly could be dry. It also certainly could be the after effects of having really significant hypertension and not being treated for a significant amount of time. Next, the patient doesn't have a history of diabetes. However, she's right on the border, and many would say hyperglycemic. So when we talk about alpha-1, right, norepinephrine, very powerful alpha-1 agonist. What that does is it increases insulin secretion from the pancreas. An alpha-1 effect in the liver actually increases glycogenolysis. So by decreasing insulin secretion and increasing the amount of glycogen in the blood, what's going to happen? The blood sugar is going to go up. Couple more clues. She had PVCs. So as you know, catecholamine sensitizes the myocardium to developing dysrhythmias. Lastly, intra-op. What happens? We talked about the ephedrine, and we've talked about when stimulation occurs with what the surgeon is doing. She has massive hypertensive episodes.
All right, so that's a lot to unpack there. And to kind of recap with regards to the signs and symptoms, there's a triad of headache, palpitations, and diaphoresis. And the catecholamines, they sensitize the myocardium to developing dysrhythmias, which is what we may see on the EKG. You did a great time breaking down the labs. So, Sass, now we got to diagnose this, right? We got to diagnose the pheochromocytoma. How does one diagnose a pheochromocytoma?
Yeah, so one gets an endocrinologist to diagnose a pheochromocytoma.
Get a specialist. Okay,
yes, exactly.
Fantastic.
So again, ideally, this is done when the patient has signs of extreme hypertension, or maybe the triad, or maybe other signs. And what an endocrinologist is going to do is a number of different tests. And I won't go into all of it because it will just bore you. They can do urine test and blood test to look at the breakdown products of catecholamines. We all have catecholamines. We all break them down, and they're in our blood, and they're certainly in our liver. These breakdown products are vanillyl mandelic acid, or VMA. Also, metanephrine, which is the breakdown product of norepinephrine. This is thought to be very indicative. In addition, there's a scan that's very specific of the adrenal gland to diagnose pheochromocytoma.
Did you say vanilly?
Not Nilly Vanilli.
Milli Vanilli.
I knew you were going to say that.
Oh, you knew I was going there.
I knew.
Remember the 90s, Milli Vanilli?
I do.
The lip sync artists?
Ooh, you said it's true, right?
Oh, just wait till we start singing on this podcast.
I'm not singing.
People are going to be dropping off like flies.
No more.
All right.
We're singing.
Okay, so now let's say we find ourselves in a situation. We arrive to work and we're like, okay, I'm going to take care of a patient with a Pheochromocytoma. What do I need to know as a CRNA preoperatively to make sure these guys are prepped and ready to go for their Pheochromocytoma surgery?
Yes. So if you know someone had a Pheo, there is a very specific pharmacologic regimen. They're going to have alpha blockade, and they're going to then, after they are adequately alpha blocked, they're going to be beta blocked.
And that's important, right?
Very important in that order. So always A before B. The typical alpha blocker is phenoxybenzamine. The drug is very potent, has a very long half-life. Once this occurs, once you give the alpha blocker phenoxybenzamine, people vasodilate. As a result, the pressure comes down, and then you can volume load them to increase their intravascular volume. Once this is done, and you know what's going to happen, the heart rate's going to go up, certainly if they're not beta blocked. And then you're going to give them a beta blockade. An example of a beta blocker for a Pheo is something like propranolol, long-acting beta-1, beta-2 blocker. The reason that you're going to give alpha blockade before beta blockade is if you gave beta blockade first and got rid of the beta-2 vasodilating effects, you're going to have unopposed alpha stimulation. And as a result, the patient can have a hypertensive crisis. In addition, when you give phenoxybenzamine and the patient vasodilates, you can also volume load them and increase their intravascular volume. You know, as we do this, right, as we vasodilate them, what's going to happen to the heart rate? Heart rate's going to go up in compensation. And then last, there's another drug that can be given for Pheochromocytoma called metyrosine. What metyrosine does, it inhibits a particular enzyme. The enzyme is known as tyrosine hydroxylase. And for you students who are listening, tyrosine hydroxylase and the inhibition of it would be important for you to know for your boards. But when that enzyme is inhibited, that enzyme is necessary for normal catecholamine creation. By inhibiting it, it overall has an inhibitory effect on catecholamine creation within the body. So a secondary way to decrease the amount of catecholamines within the sympathetic nervous system.
Okay, Sass, so how do we know? How do we know that somebody has been adequately preoperatively optimized for a pheochromocytoma before we actually take them into the operating room?
Yeah, and there's a very specific criteria. I'll go ahead and read them to you. So someone with a pheochromocytoma who has gotten adequate pharmacologic control should have no blood pressure that exceeds 160/90 for 24 to 48 hours preoperatively. Orthostatic hypotension should exist, which makes sense. If the patient has very potent alpha blockade, orthostatic hypotension will exist. The EKG should be free of ST and T-wave abnormalities for at least 1 week. And the patient should have no more than 1 PVC every 5 minutes. There's one last alternative criteria, and that is hematocrit dropping by 5%. And that reflects volume repletion as someone now isn't as tightly vasoconstricted.
Okay, so now how about drugs to avoid? You know, you've already talked about alpha blockade before beta blockade, but are there any other drugs that we should avoid giving somebody who has a pheochromocytoma?
Yeah, so let's go through the list. So let's start with inhalation agents. Desflurane, as you know, turning the concentration up rapidly can cause sympathetic nervous system stimulation. That's the last thing you would want to do with someone with a pheochromocytoma. So that drug would be out. When we talk about neuromuscular blockers, drugs that, or really any drugs that release histamine should certainly be out. if it releases histamine and the blood pressure goes down, that's going to create a sympathetic nervous system response. So drugs like atracurium, mivacurium that release histamine are a no. Narcotics such as morphine, which releases histamine, is certainly a no. Succinylcholine is one of those drugs that it's kind of controversial. Succinylcholine, because of the fasciculations, can cause the release of catecholamine from the actual